Welcome to this introductory module on person-centered language for individuals who work in emergency departments. We will explore language, power, and stigma. In this module, we will do the following. 1. Explore how power is implied through language. 2. Explore the origins of bias and stigmatizing language in healthcare. 3. Recognize the impact of stigma and bias on the language we use. 4. Define person-centered language. The words we use reflect many things: power, control, judgment, bias, stigma. In this module, we will learn about how the words we choose can have meaning beyond the actual words themselves. There is an inherent power dynamic in healthcare, with the healthcare team typically having the greater balance of power and dominance. Our language reflects this. When we speak of patients claiming or denying a symptom or experience, we are casting doubt on the truthfulness of their words. We are inferring either inaccuracy or intention to mislead. Terms such as non-compliant or poorly controlled reflect a power dynamic in care provision and cast the patient as a troublesome part of the interaction that is not pulling their weight or doing what they were told. The teller has the power and the recipient must listen and obey. This dynamic infantilizes patients and renders them powerless. Think about the words typically attributed to the healthcare team: orders, protocols, plans. These words carry weight, importance, power, and dominance. They speak of things to be followed and adhered to. The first step towards a more person-centered way of thinking and speaking is to become aware of power dynamics and how they are reflected in our language and ways of doing. The words we choose matter greatly. They convey much more than the actual meaning of the word and can create biases or preconceived ideas about our patients. The words in the center of this slide have a negative bias and make it seem that the patient is inaccurate, lying, malingering, or misleading the care team. Phrases such as failure to cope imply that the patient is at fault. Many health professionals are unaware of the bias and judgment conveyed. These words and phrases are often used and can be found in documentation forms. Something to think about. Which of these two statements have you heard more often? Patient claims pain is 10 out of 10, or doctor claims to have heard S3 heart sound. Why is this? Because the words we use reveal who has power and who does not, who is to be believed and who is not. The key point here is that words reveal power and dominance. Stigma is characterized by labeling, negative stereotyping, and separation or exclusion, othering, and leads to a loss of status and power. Stigma affects a person's willingness to seek or accept care, quality of life, and leads to feelings of shame. We have a bias when, rather than being neutral, we have a preference for or aversion to a person or a group of people. Thoughts and feelings are implicit if we are unaware of them or mistaken about their nature. We use the term implicit bias to describe when we have attitudes towards people or associate stereotypes with them without our conscious knowledge. It is important to note that we all have implicit biases. It's normal. If we all have implicit biases, how are they acquired? Stigmatizing language and implicit bias towards patients is acquired from one another in written or spoken words, such as transfer of accountability or patient care rounds, through reading medical records, and as part of a hidden curriculum in our education and organizational processes, such as health and social care policy, strategic frameworks, validated tools, or from leaders. For example, the medical hierarchy and prevailing approach to patient care is to refer to people by their diagnosis or behavior. The fractured hip, COVID patients, or violent patient in room 5, rather than by their name. Systemic processes such as language found in electronic medical records, validated tools, or legislation, i.e., agitation scales, restraint documentation, or Form 1, implicitly and explicitly reinforce the use of these biases and stigmas. Stigma and implicit bias lead to inaccurate assessments of patients, inaccurate expectations of behavior, and exclusion of patients from decision-making and care planning. Studies have shown that two main factors affect the burden of stigma placed on a particular disease or disorder: perceived control that a person has over the condition and perceived fault in acquiring the condition. When we believe a person has acquired their illness through no fault of their own and/or that they have little control over it, we typically attach no stigma to either the person or the illness. For example, advanced metastatic cancer or end-stage renal disease. But when we perceive that the illness or behavior is under the control of the person, we feel that they are at fault. For example, substance use disorder or responsive behaviors of dementia. Have a look at the admission diagnoses listed on the right-hand side of this slide. Which ones convey perceived fault or control over the illness/disease state? The perceptions of fault, control, and blame are higher for poorly controlled diabetes, dementia, challenging behaviors, and confusion, failure to cope. In each of these, there is an underlying assumption that the person is at fault, not doing their best, and is less worthy. The perceptions of fault and control are lower in the diagnoses grade 4 left ventricle end-stage cardiomyopathy, metastatic ovarian cancer, and exacerbation COPD. In these diagnoses, the language used is free from bias, judgment, or stigma and implies that the patient is less able to control their illness and is less at fault for their current medical situation. The stigmatizing, labeling, and blaming words poorly controlled, challenging behaviors, and failure to cope imply that the patient is at fault and hasn't done what they were meant to do. Think for a moment on how you might word those admission diagnoses differently. What can we do about bias and stigma? Firstly, be kind to yourself. Understand that implicit bias is normal. Implicit bias and stigma are systemic issues with individual impact. To overcome these, it is helpful to reflect on your own biases and the potential impact they may have for patients and colleagues. Then, take steps to broaden your viewpoint and educate others. As Maya Angelou once said, "Do the best you can until you know better. Then, when you know better, do better." One way to do better is to use person-centered language. So, what is person-centered language? Person-centered language is language that is specific, objective, and respectful. Let's begin by learning more about this definition. Specific, objective, and non-judgmental descriptions of the behavior help us to see the person first and prompt us to gather information about the patient to guide care planning. On this slide, we explore person-centered language in more detail. Person-centered language is specific. This means writing a brief description with precise details on the who, what, where, and when something has happened. Using specific language allows other team members to easily understand what you are describing, with less room for misinterpretation. Specific language enhances our ability to plan and evaluate patient care. It enables the team to implement interventions and evaluate their effectiveness through the use of clear details that are not open to misinterpretation. Person-centered language is objective. When we use objective language to describe our assessment findings, we use observable or verifiable facts and not personal opinions. What we write will influence the next clinician who interacts with this patient. The words used in a patient's chart can follow them throughout their stay in hospital and can influence the discharge planning process and access to long-term care. Person-centered language is respectful. This means using language that avoids labeling or infantilizing the patient. The language we use can promote, empower, and increase self-esteem, or it can demean, devalue, and disrespect those it refers to. Through our language, we can demonstrate a recognition of identity, personhood, and respect. Using specific, objective, and respectful words when we communicate with older adults means our conversations don't condescend or infantilize. Person-first language helps us to see the person rather than only the diagnosis and helps to reduce the potential for stigmatization. Introducing the person first and the condition or disability second suggests that the person has a problem that can be addressed, rather than implying that they are the problem. So instead of dementia patient or dementia victim, we would say person with dementia. Instead of substance abuser, drug addict, or drug seeker, we would say person with a substance use disorder. Instead of suffers from depression, we would say person with depression. When in doubt, ask the person what they would prefer to be used to introduce or describe them. The words we use have long-lasting impact and will be repeated throughout a patient's stay in hospital. They are sticky. Think back to the childhood game of broken telephone, where you were tasked with repeating a phrase or sentence. Like this game, the language we use in change of shift reports, transfer of accountability, or our notes gets repeated over and over. Colleagues from many disciplines read and hear our words and are influenced by them either consciously or subconsciously. So, what can we do? We can use person-centered language that is specific and objective language instead of sensational or fear-based language. We can avoid words that make it seem as if the patient is unpredictably volatile or a threat. We can be aware that some labels and language may induce explicit and/or implicit biases, and that language that belittles or blames the patient has negative impacts on the therapeutic relationship. When we use labels, we talk and think about things to be managed instead of people to be understood. Using person-centered language in healthcare is one way of addressing the individual impacts and the beginning of a revolution in how we think and provide healthcare. Together, we can harness the power of language to reflect our assessments and care in a person-centered manner.